now entering the third year since the onset of the COVID-19 pandemic. While we've all learned to adjust our behaviors and to cope with each new variant that arises, it continues to profoundly impact all of us. With that said, it is my pleasure to introduce our panelists. We have Sabel Raver, Vice Chancellor for Academic Affairs and Provost, Pam Jones, Associate Vice Chancellor for Health and Wellness and co-leader of Vanderbilt University's Public Health Central Command Center, Isaac Thompson, Associate Professor of Infectious Disease and Director of Vanderbilt Vaccine Research Program Laboratory, and Jim Kendall, Manager of Work-Life Connections. We will be taking questions that were submitted in advance of the town hall through the Q&A session with each of the, or during the Q&A session with each of our panelists. Additionally, we have enabled Zoom's question and answer feature during this town hall so we can take live questions. I'd like now to welcome Provost Sabel Raver to say a few words.
Thank you so much, Mark. Your leadership has been and remains so central to our shared mission. I really thank you. And I'd really like to also thank our panelists and everyone else who's organized this town hall. Like many of you, we've been actively monitoring the data for COVID-19, and Chancellor Diermeyer and I were in touch with key members of our health, operations, faculty, and student teams over the winter break, really working around the clock to meet our highest priorities, namely to be able to offer the highest caliber in-person experiences for our students while also working to keep our campus healthy and safe. Still, I understand that many important questions remain. Some of your questions will be answered by our excellent speakers and our colleagues. Other topics, like so many elements of this pandemic, will really require further analysis and evaluation. As we start the semester, please know that I'm immensely grateful to you, our faculty, for your creative thinking and your dedication to these issues. As faculty members, you are vital to upholding our university mission, even in the face of these pressing challenges. One thing we've learned more recently is that we must keep a close watch, not only on students' physical health, but also on their mental health and well-being. It's become increasingly clear to me and to my colleagues who serve as provosts of other universities that in-person experiences, whether in the classroom, in research labs, or on the playing field, are central to our students' positive experiences and welfare. Therefore, we're really committed to continuing in-person learning this semester, and we will do so with an abundance of caution. The core principles that fueled us through the fall semester will not change, and these include, for one, our commitment to highest level scholarship and research. Many of you run your own programs of research, scholarship, and creative expression, whether that's in the lab, in the archive, or in the studio. We're committed to doing all that we can to support you in keeping your research operations running. We also remain dedicated to training and inspiring future leaders through in-person residential learning, and our impact through teaching is monumental. I may have mentioned in earlier presentations how impressed I am by the sheer number of courses being taught. This spring semester, faculty are teaching 1,793 undergraduate courses and another 1,500 graduate and professional courses. Not only do they teach, or do you teach these courses, but there's also obviously off-campus work, research, dissertations, and other immersion experiences that you are really making possible. These numbers suggest both a capacity and such a high demand for high levels of in-person learning and engagement on the part of students. We're able to uphold these principles thanks largely to our exceptional vaccination rate of 96% across the entire Vanderbilt community. And we can find reassurance, I think, in the fall 2021 data regarding on-campus cases. For example, from the weeks of August 22nd through the weeks of December 12th, 2021, the percentage of unvaccinated individuals who tested positive for COVID-19 only reached above 1% about 3 times. This is in contrast to the vaccinated community, where rates are even lower, for whom positive tests never went above 0.6%, and in fact averaged just under 0.2%. These numbers are a source of pride, but they also do not negate the need for everyone in the community to follow protocols. Based on what we know so far about the Omicron variant and its high transmission rate, we can predict that we will see higher numbers this semester. Thankfully, recent studies and evidence show that these Omicron cases have been ones with milder symptoms. Pam will discuss some of these trends as well as our new protocols for the semester shortly. In closing, I really want to reiterate that we are fully committed to your well-being and to advancing the systems and pathways through which your work can thrive. I also want to personally thank you in advance for all the creativity you use to adapt your teaching and your research to yet another set of challenges and disruptions caused by this latest variant. At such difficult and complex moments, your work as scientists, as artists, as engineers, as thought leaders is especially vital. Thank you so much for your perseverance and commitment. And thank you, Mark, back to you.
Thank you, Provost Raver. Those are very nice comments. I'd like now to turn it over to our first panelist for today, Pam Jones. Pam is Associate Vice Chancellor for Health and Wellness, Associate Professor in the School of Nursing, and co-leader of Vanderbilt University's Public Health Central Command Center. She's helped to navigate us through this crisis for the last 2 years. She will talk to us about the latest COVID-19 trends on campus, what we currently know about the Omicron variant, and our testing and contact tracing protocols for the spring semester. Pam.
Thank you, and I hope you can hear me okay. I apologize profusely for not being on camera today, but I'm traveling and having some technical difficulties. So thank you for allowing me to be here. So let's start first with the Omicron variant. And as the provost said, we are beginning to understand more and more about it. And one thing that we do know is it is much more contagious than previous variants, including Delta, which was more contagious than others. But vaccination, and Dr. Thompson will address this more in his remarks, but vaccination does, it doesn't 100% protect you from getting infected. And we know that if you're not boosted, you are more likely to get infected than if you are boosted. But it does continue to prevent severe illness for most people. Experts keep talking about when we're going to peak with this variant, and we are watching closely what's happening in South Africa and the UK to try to get a better understanding of the predictive modeling for our country and our community. It's a little hard to say because you can't directly compare our population to the population of South Africa. It has a lower vaccination rate as well as a lower median age. But most people think we're going to peak in middle to end of January. We're working with our experts at VUMC, Hugh Shear in particular, to use his modeling data to help inform us. But again, we're watching it very, very closely. As the provost said, the only potential silver lining in this situation is that Omicron, based on current research, looks like it is going to cause less severe illness. It tends to colonize in the upper respiratory system versus deeply in the lungs. And as you all know, so much of what happened in terms of severe illness with prior variants of COVID was the damage that occurred in the lungs and the difficulty actually, ventilating people. So far, hospitalizations are pretty steady. But again, we need to continue to take this seriously because we don't want to overwhelm our healthcare systems. And right now where they're struggling is not really around hospitalizations, but is around testing and outpatient capabilities. So that's essentially what we know. What we don't know is what we don't know about Omicron. We will be watching it closely and again, adjusting plans accordingly. So for our current cases, we are seeing an increase in faculty, staff, and students, both in Nashville and outside of Nashville. The vast majority of these cases we're seeing are reporting minor symptoms that resolve quickly within a day or so, typically. However, some people have lingering illnesses that goes beyond that. Again, as always, we're watching these trends very carefully. So what are we seeing in contact tracing? And we continue to contact trace. Our cycle time's not quite as quick as it was last semester just because of the case numbers, but we continue to contact trace. and prioritize cases to be called first for people who are on campus, living on campus, those types of things. So we're seeing a number of household contacts. So people in their families have become positive and therefore they have become positive. We are seeing travel and travel related trends for sure. We are seeing clusters in friend groups. So people who go out to lunch together, to dinner together, spend time together. We're seeing clusters in those groups. And we're seeing some spread in work groups that spend a lot of time together, but not a typical work environment. These would be people who tend to eat lunch together and tend to, talk in the hallways and those kind of things associated with work. We have implemented the new CDC recommendations for decreased isolation period for those who are, for individuals who are positive. And those guidelines allow for release from isolation at 5 days post either exposure or a positive test, assuming symptoms are improving and the individual does not have a fever for 24 hours with no fever reducing medications. And that is helping a lot in terms of getting people back either to work or school or back to their regular housing. You may see some changes in contact tracing. We're working on automating part of the process for more simple cases, which will create additional capacity for us to manage any surges that we may continue to see. So let me test on testing and our new protocols. As you know, we are requiring students to test before they come back to campus, or for faculty and staff to test before returning to campus activities. And many of you will have already tested this past week prior to our little snowfall that happened, and hopefully gotten your results from that. We are seeing some asymptomatic results coming out of that, but not a lot. And we do have a retesting program, because one thing that happens sometimes is if you haven't tested and then you go through an asymptomatic testing program, it may pick up a test, that was should have been positive previously, and you're not actually spreading. We know that our saliva test that we use is extremely sensitive. There's some new actually research out that shows it's very sensitive against Omicron, which is a good thing for our testing program overall. So some of you may test positive and then test out. We have a retesting program. And if you have 2 consecutive negatives, that is considered a prior positive and you are not required to isolate. Symptomatic testing remains available through Student Health Center and Occupational Health Center. And we're very grateful for that, because as you know, in many communities, people are really struggling to get symptomatic testing. And then we did announce our revised asymptomatic testing program for the fall, which includes those individuals who do not provide proof of vaccination must test 2 times a week. Those who are vaccinated but don't provide a proof of booster must test 1 time a week. And boosted individuals will go into our Sentinel testing program. As you recall, we used that last semester as a surveillance program. And we are going to increase the sample size of that Sentinel testing program. So I'll stop there and just re-emphasize a couple of messages. One is we are actively engaged, watching all of the trends. All of the options are on the table, and we work very, very closely with leadership to consider all of those options. Boost, boost, boost. Everybody needs to get a booster, and we'll discuss that more later. And then again, we have implemented universal indoor masking and recommend a KN95 or equivalent mask for such. So I'll stop there.
Thank you, Pam. That was certainly helpful to learn about the many efforts that are taking place to help us navigate through this. And your expertise on the matter is very evident. We wanted to follow up with some additional questions. So let's start with the first one. Some faculty have expressed concerns about being able to find a COVID test to submit for the return to campus testing deadline on January 14th. Can you talk through their options?
Yes, I can. The easiest thing is to go to our testing center at the David Williams Recreation Center that we've had there we're almost a year and a half now, I guess. And we opened that testing center next Sunday. So it will be available Sunday through Wednesday of next week. The hours and details are posted on our health and safety protocol website. So that's the easiest thing to do. There is drive-up testing available. So you can actually be tested in your car if that is your preference.
Okay, another one. What is Vanderbilt's plan if we were to experience a major outbreak or influx of new cases?
So again, our strategy all along has been to be very facile, and we meet frequently. Andrea George, my wonderful partner, and I watch all of the data as it evolves. We are in clear and constant communication with senior leaders, and we would put contingency plans in place as appropriate, depending on what the circumstances were, which part of the system was under the most stress, and what our major concerns were.
So looking ahead to once the Omicron wave has passed, what kind of metrics and endpoints are being used to determine when masking requirements and other restrictions will be relaxed on campus? Are we looking at cases, transmission rates, vaccination rates, hospital capacity, or something else? Are we focused on campus numbers, Nashville community numbers, national numbers, or other information?
So that's a really great question. I think, again, the answer is all of the above. We watch all of those trends, as well as other international situations. So for example, the South Africa situation with this variant informed us quite early on that we were going to have to put additional measures in place. So we will watch all of those things, and we will also seriously consider what the CDC recommendations are, because we tend to follow those very, very carefully, even sometimes when they feel like they might be a little bit of overkill for us. So we will watch all of those things, including the CDC recommendations.
You touched on the Omicron variant. Can you tell us more about the trends and what the models are predicting about the variant over the next few months?
Yes, we know we are going to have a large number of cases, both in our community and probably some, higher than we expected cases on our campus. Again, we believe the vast majority of those will be mild and not have significant illness associated with them. We hope that the peak will happen mid to January or towards the end of January, but the modeling has got a lot of room for error in it right now. So that's what we know. And again, every day the boots are on the ground, kind of watching what's going on and trying to be as reactive as we can.
Thank you, Pam. These are certainly very helpful and informative updates. Now I'd like to welcome Isaac Thompson, Associate Professor of Infectious Diseases and Director of the Vanderbilt Vaccine Research Program Laboratory, who will share some details about the COVID vaccine and its effectiveness against different variants. Isaac, if you could share your expertise on this from the perspective of faculty who have received the vaccine, and maybe take a moment to touch on the vaccine for children, to give us some information, particularly parents attending today's events.
Sure, happy to touch on those, and thanks for having me. I'll maybe just start with addressing things that kind of the common questions we're getting about a lot of these aspects right now, and then certainly time for specific questions from the folks on here today. So I think to start with, a couple of notes on the Omicron variant. We're clearly in the midst of that surge right now. I think the infectivity of this variant speaks for itself. I would be willing to bet that maybe no one on this call is without some contact in their network that has current or recent Omicron. I mean, it's all around us. The asymptomatic carriage rate in our community right now is over 10%, maybe over 15%. At least 1 in 10 people all around us have Omicron at this moment. It's staggering, and it's unprecedented at any point in the pandemic, as our current case rates by far. As Pam mentioned, the small silver lining on that, it appears with every day as we get more evidence and knowledge on this, that person to person. It is less severe disease. There's a much higher predilection for the upper respiratory tract. We're seeing severe sore throats and laryngitis and those types of aspects, which are unpleasant, but much better than the pneumonia and some of the very severe disease that was hallmark of the Delta variant, for example. We await good epidemiologic data on things like critical illness rate, hospitalization rate with Omicron. What it looks like out of the UK is compared to Delta, hospitalization rates are a third to a quarter, maybe, of what they were with Delta. So that's great news per person. But if we balance that against a massive number of cases, we still run that same risk of overwhelming our medical systems if we aren't careful, as Pam touched on. So there's a need for a lot of balance there. What is also very clear about Omicron is its ability to evade initial vaccine barriers of defense, right? So we're seeing far higher numbers of cases in vaccinated people. It's tough to assess that because we also know that, in the absence of boosters, it's now been quite a while since vaccinated people got their initial vaccines. And so that's a confounder as we try to assess the rates of Omicron's ability to break through. But it does seem its significant and potent transmissibility, infectious capacity is clearly able to get around vaccine. But I think I want to take a moment to focus on this point because I think it's crucial for all of our understanding of the fact that that is still not a vaccine failure. And in fact, it's been a little bit unfair of us to expect vaccine to prevent initial infection. That's not even the interface between vaccine immunity and the virus, right? So this is a respiratory infection. We inhale this, someone speaks near us, and we have Omicron in our nose and throat. And there's nothing that a vaccine can do to block that initial influx of virus. Earlier variants of COVID, we did see pretty significant, even just initial reduction in infection rates. And so the way I have an analogy that I'm fond of, if I might share that, is I think about it as sort of a home defense system. And what the vaccine does is it locks down the house. So that's severe illness, hospitalization, death. It also builds a little bit of a fence around the yard, maybe out near the street. And those earlier variants, the quaint days of beta COVID that we had, the vaccine was pretty effective even at preventing that initial influx in. Delta was our first variant that cleared that fence pretty easily, and Omicron just flies over it. So it gets in the yard, it starts messing around on the porch, it might even steal your lawnmower, but it's not getting all the way into the house, right? We still are seeing potent protection against severe illness, hospitalization, death. And that's what the vaccine is supposed to do. And so along those lines, many of us in our field have really grown to dislike the term breakthrough infection. I think breakthrough infection implies a failure of the vaccine. It implies that the virus fully busted through and got around the vaccine. What we see when we see illness in a vaccinated person is vaccine limited infection. And so I hear all the time, someone sort of comes and complains to me, hey, I got vaccinated and I'm still positive, as if it's some failure. And I say, well, thank goodness you're vaccinated, right? So you just with that, you're tremendously lower rates of severe illness. And in fact, as I see here right now, I don't know of a single case in a fully vaccinated person with Omicron with a normal immune system, as far as we know, with severe illness, hospitalization, or death. They're overwhelmingly mild. Now, fully vaccinated to me includes a booster. So my definition of fully vaccinated right now would be the initial series plus a booster, unless the initial 2-dose series was very recent. So why is boosting so important? And I think Omicron is really driving this to the forefront. There are a couple of reasons. One is that we know that vaccine immunity fades over time. We don't have really clear, perfect models of this yet. How could we? It hasn't been long enough, right? It's been less than a year since widespread vaccine rollout. We don't have a perfect handle on the rate of degradation of antibody responses and T cell responses and those sorts of things. But we clearly can see from effectiveness data that after 5 to 6 months after that initial series, we've lost a significant layer of defense. That's where boosting comes in. So one advantage of a booster is just simply it's a more recent dose. But it's more than that. Immunologically, it's actually a lot more than that. There is a major benefit of challenging our immune system with vaccine stimulus spread out in time. So I think one thing, and you may have seen some coverage about this recently, the the very close together 2-dose series, 3 to 4 weeks apart. That was done because a year ago we were trying to vaccinate people as fast as we could, and it was literally called Operation Warp Speed, right? We were going as fast as we could. 3 weeks apart from a vaccine standpoint is a little too close to get a really long-lasting, robust immune response. So we had a trade-off there. We sacrificed a little for durability so that we got rapid immunity early on. And now we're paying the price a little bit for that durability. And so those that are unboosted are relying on a suboptimal initial vaccine series. And so a booster, in addition to being a more recent dose, it's also going to be significantly more effective in generating a durable memory response because it's further out in time. So think about our infant vaccine series. We do it 2 months apart at least. It's spacing between vaccine doses is important. And so a booster provides a spaced dose and an additional dose. And we're seeing from just population effectiveness data that it's crucial for prevention of Omicron, especially those that are unboosted, while still get some protection, much, much higher risks of infection in general and significant illness. Along those lines, I want to touch a little bit. I know there are many parents on the town hall today, and I spend a lot of my time treating children with infections. And so I think there are some significant issues. You've probably seen a lot of the press coverage about unprecedented rates of pediatric hospitalizations with the Omicron variant. There are a couple of reasons for this. The biggest one is that this remains our profoundly under-vaccinated population. Certainly we have no vaccines available for those under 5, but even in the 5 to 11 age range, we have what to me are heartbreaking rates of vaccination. There are many counties in Tennessee, 6%, 7% of children 5 to 11 are vaccinated. There was one county in Southeast Tennessee that, at least as of early December, not a single child 5 to 11 had been vaccinated for COVID. So this is heartbreaking to us, as we have a very safe, very effective method of preventing disease in children, and we're now seeing the effects of that. The overwhelming majority of children hospitalized with COVID are unvaccinated. The few that aren't, almost all have underlying medical conditions or risk factors. Vaccine, just as we have said in all populations, it is significantly effective against hospitalization. So I have the conversation every day with families who feel like they are protecting their child from a vaccine, and these issues of, well, we don't know about long-term effects, and these issues that are unfounded, and it's just anxiety and it's fear. And I just try to turn that into say, what you need to do is protect your child through the vaccine. What we need to be afraid of is this variant that's rampantly infecting children at unprecedented rates and hospitalizing them. Now, where the big issue still remains is those that are under 5. We don't have a vaccine available for those. And I think it's a really challenging situation right now for families that perhaps may have school-age kids, but also have young children, toddlers, that sort of thing. It's all about layers of protection, vaccinating those that can. And all of my framework that I would share with you about defense against this extremely infectious variant is it's layers of protection. So masks still work. They are still helpful. They aren't perfect. Nothing is perfect. Nothing is a binary yes, no, protected, unprotected. It's all layers of defense. So recent vaccination, vaccinating everyone that can, avoiding crowded indoor situations that are unmasked, those things all get stacked up, and we have to have a shell of protection around those that are the most vulnerable, like those that are under 5, those with immune compromise that may not be able to respond to vaccines, that sort of thing. And I guess final point I would end with that I think is challenging about Omicron, as Pam mentioned, what we don't know is what we don't know. A lot of the big blinking lights of what we're desperate to learn about new variants all the time are these other aspects of COVID that are somewhat unique to this virus, like long hauler symptoms, long COVID. We have no idea what Omicron's rates of this are going to be, right? Again, how could we? It's too new. We haven't had time to get into it. There aren't computer models that have any way of predicting this because we don't understand the underlying physiology. So all we can do is wait. So we don't know about the risk of long hauler COVID with Omicron. We do know that from other variants, vaccine was protective against rates of long COVID. And in fact, very fascinatingly, on an immunologic level, many of people who had long COVID, and then when they got vaccinated, their long hauler symptoms went away. So there is some protection from vaccine, at least for other variants. We also don't know about things like the post-infection inflammatory condition, MIS, multisystem inflammatory syndrome, very common in children. We have no idea what the rates of that will be with Omicron. We'll await data soon out of South Africa and other areas that had this earlier, but we'll just have to see. So it's back to principles of exercising caution, taking this seriously. But I would say, I guess, to end on a note of a bit of optimism where we can, that on a per person level, given the fact that we have freely available, miraculously effective and safe vaccines, a full vaccination regimen, which includes a booster, is extremely effective at preventing an illness on the individual level. And so I think that that can hopefully reduce our individual anxieties about this. And as we just sort of craft into a societal response, keeping our most vulnerable safe until we have this under control. And maybe if there's time later, we could talk about things like the end game and where we're going with this and when does pandemic become endemic and those sorts of things. But maybe I'll pause there so we can be a little more targeted with questions, and thanks again for having me.
Thank you, Isaac. You explain things in such a nice way. The immune response is certainly complicated. Our next panelist is Jim Kendall, manager of Work-Life Connections. Jim, before we jump into questions, can you tell us a little bit about what Work-Life Connections is doing to support faculty through the year, and more specifically during the pandemic? And before you get started, I think everybody realizes that, the pandemic and COVID is just adding additional stress to already stressful lives, and you play a big role in this.
Well, thanks, Mark. Absolutely. We're living in a very complex time, and that's not a surprise to anybody. This has been hard on our mental health. And we know that anxiety and depression have spiked since 2020, and it's taken its toll. A lot of us have experienced the fear of infection, and we continue to have that heightened in recent weeks. We've adapted to so much, and there's been grief associated with those adaptations and losses. I think we're coping with a lot of changes. Unfortunately, there's misinformation out there, and from time to time, there are additional stressors that we all have in our lives, childcare issues, and so on. But I always want to remind people that we all have experienced pandemic trauma and stress. And the pandemic trauma and stress experience, PTSD, has been identified by the American Psychoanalytic Association. And it's not a diagnosable mental illness, but actually it talks about a shared experience that we've all had. We have all had increased stress, grief, loss, and we've seen remarkable resilience. And the definition of pandemic trauma and stress experience includes a buildup of emotional and interpersonal disruptions, because we continually have to adapt to the next normal. And we do that. I think we've done that extremely well, but none of us like uncertainties, and we don't like that feeling of danger out there. And so we all are doing our best, but it does take its toll on us. I think everyone's tired, and so many people that we see in the community are on a shorter fuse. So sometimes we all have to just pause and compose ourselves, take a deep breath, and give each other a little bit of grace. And Vanderbilt has a resource that I want to make sure you all know about, and that's Work-Life Connections, which is an employee assistance program that's internal to Vanderbilt, contracted, and we serve our faculty, staff, and postdocs. Now, an employee assistance program is designed to identify and assist employees in resolving personal and workplace stresses through individual assessment, brief solution-focused counseling, performance coaching, and community referrals for more specialized care. So we also provide strategic work group dynamic support to leaders and teams, and a lot of folks don't really know about that. So I want to let you know, with all the uncertainty of the coronavirus, organizational changes, and the continued adjustments that we're all making, we have the opportunity in a lot of cases to join team meetings, departmental meetings, to address well-being and hopefully normalize conversations about the importance of mental health in the workplace. And we would welcome an invitation from your groups to be able to join on a periodic basis to provide some skills and also conversation around that. And unfortunately, in an enterprise this size, there are challenging events that occur. Sometimes there's the death of a student, the death of faculty, staff members, or other stressful incidents that affect the well-being of our Vanderbilt community. And Work-Life Connections facilitates critical incident stress management, group discussions to process the emotional impact that those events have. And so I want you to know about that. All of our services are confidential, and we offer them both virtually, but also in person. Of course, we're masked, and we want to make sure that we're all safe. And so I would like everyone, if you're willing, put our phone number in your contact list, 615-936-1327, so that if you or a coworker is struggling, you'll have that handy resource available. And the last thing I just want to say is the roadmap for dealing with this pandemic storm, and also, speaking of storms, what we're dealing with today is we've always got to acknowledge what we're feeling and thinking. And we need to strive for that patience and tolerance in ourselves and others, because this is imperfect. We are navigating in uncharted waters sometimes, and it may be imperfect, but we're going to get there. And we have to practice in acceptance. We're all trying to do the best. But we really need to take personal responsibility for our own self-care. That is critical right now. It is essential. We need to exercise. We need to nourish ourselves. We need to mindfully take breaks from all this heaviness. And I recommend breaks from news. And make sure you're connecting with people that nurture you. Find that deeper gear and listen, validate and engage with each other. Again, please put our phone number in your contact list. It is 615-936-1327, so that you can reach out if you're having difficulty or if a coworker needs that as well. Thank you so much.
Thank you, Jim. That's great information. I'm going to jump in now to questions that were submitted both in advance and have come in live from people in attendance. And I should note before we get started that Vice Provost Tracy George will join us to answer some of the submitted questions. I'm filtering these to some that I think are going to be most important for the audience. So I'm going to start with the question for Sabel or Tracy, and that is, why is the university not providing virtually accessible instruction for students who do not want to expose themselves to COVID-19 in class, by attending in person?
Take that initially. Thank you, Mark, and thank you to everyone on the panel for such an enlightening discussion. I'll chime in with Eve Rifkin, who noted this has been one of the most valuable discussions that I've heard. So I think I would return to the principle that we've really reinforced throughout the pandemic, which is our sincere, serious commitment to the value of in-person education. And that in-person education is what we're expert at, and therefore we're going to prioritize that in all of our work. That said, we also recognize the importance of supporting our students and faculty, and in particular here to the question, supporting students who are unable to come to class. This is not a new phenomenon. This is not something unique to the pandemic. We've certainly, even before COVID, had situations where due to outbreaks of the flu or other issues, we've had students who've been unable to attend class. And we're going to lean on those tools that we developed before as a way to effectively engage them in the classroom. We are not going to return to hybrid education in a world where we've determined there is a safe way for students to be in the classroom. Until we determine otherwise, our expectation is that students will come to class in person. So how do we do that? In my own experience, what I have done is I've recorded some asynchronous content for students who are unable to attend class or offered to meet with those students virtually for additional office hours. I know that colleagues across campus have been doing the same. In truth, we had very few students quarantined in the fall for whom this was an issue. Again, though, we will keep an eye on that. And if we need to, we'll make adjustments as necessitated. But as always, feel free to contact me with your concerns. I'm always happy to try to work through with you ways that we might respond.
This may be another question for Tracy, and it's a big one. Could you tell us what the revised academic schedule will be for the spring? How will we still be able to have 14 full weeks of the semester, even with some schools starting a week late?
Great question. And I know for all of us, particularly starting back later, trying to make sure our syllabi makes sense, this is a very timely one. We historically, as we're all aware, had a fairly long period between the end of exams and commencement that was originally designed as a way for us to provide physical diplomas at graduation. This is the first institution where I've been that we actually tried to accomplish that feat. What that has meant to our advantage during COVID is there are additional days available to us in the calendar before commencement that we can use for purposes of protecting class days. So we are not decreasing the number of class days in the semester. Instead, we're simply going to end classes later in the undergraduate and graduate programs for undergraduate programs, for sure, that's April 29th. For professional schools and professional programs, the dates are different. You should speak to your dean's office to confirm the specific dates. I won't try to review them here, but bottom line, we are not losing any instructional days, are still able to preserve spring break and keep the same date for commencement.
Thank you, Tracy. And this one is probably for Pam. Will faculty, students, and staff be required to wear a N95 or KN95 mask in campus buildings this semester?
So great question, Mark. Universal masking is required indoors. N95s are difficult because true N95s have to be fitted, and it's virtually impossible to implement a fit test program for this large a population. So what's being recommended for the general public, which are the guidelines that we fall under, are KN95 or a similar mask type. And I recognize that there's some issues with expense and availability of those masks. We are working through, should we have any options of creating some surplus for people. But right now, the recommendation is that individuals get those masks and wear them. Certainly a cloth, a surgical mask provides some protection, but the literature is developing that KN95s really are far more effective against Omicron than prior masking. Double masking is also not a bad idea, and you can look at the CDC recommendations to get the most current recommendations on that.
Excellent, that's very helpful. Another one is, I think, and this probably goes to you, Tracy, how are we going to ensure people follow the university COVID protocols and guidelines? Who do we get in touch with if we see VU community members not complying with the policies, such as wearing masks indoors and not maintaining physical distancing?
This is obviously, Mark, thank you for directing this question to me. This was obviously a point of particular stress now, in the fall of 2020, when we were new to this process. And I will say, as I give my answer, I do not view it as the responsibility of faculty to serve as police in the buildings or classrooms, right? That's not our responsibility. It's not what we're trained to do. So I would think about this question, given this is a faculty town hall, from the perspective of what we do in our role as faculty. Our responsibilities to advise our students and educate them. Everyone makes mistakes. I've had faculty forget to put their mask on when they're teaching, right? I've had students forget when they've walked into a building. Let's grant each other some grace and assume that people are trying to proceed in the best interest of everyone in our community. And the reason to do that is actually that's how our community behaves. It's one of the things I love about Vanderbilt and attracted me to come here. So if you have someone who comes to class and you feel their nose is too visible from their mask, rather than calling them out in class, it'd be really great if you could try to think of an opportunity to speak to them outside of class. I also have asked students not to send a hotline message when they see a faculty member doing the same, because I know faculty are trying to comply. If you think there's a persistent problem with an individual, rather than escalating it yourself and getting into a confrontation, why don't you think about who you would normally contact if you have a problem with a particular staff member, colleague, or student, and ask for their help. And finally, I just want to reinforce what Pam said. Universal masking is required. Unlike the fall, where we allowed instructors to go without a mask when they were in the front of the room and socially distanced, we are no longer doing that. It's just too important that you have a mask on at all times. If possible, a KN95 mask would be ideal, but we're not requiring that yet. We're simply, like the CDC, recommending it as the best option.
I think you just answered this next question, but it's an important one to emphasize. If I'm lecturing in a large hall where I can maintain physical distancing, do I still need to wear a mask while I teach?
You do. We'll let you know. We're constantly reevaluating that. And as someone who taught in a mask all of spring 2020, please trust me that I will be constantly reevaluating that question to try to see if we can change the guidance on it, because I appreciate how difficult.
Thing on Twitter trending about the let it rip idea, and just let it go and let it rip and let everybody get it and be done with this. There are a couple of major problems with that. Number one is, even if it is mild for most people, it's not mild for all. And we don't yet have, so where the end game goes is when we have those that are vulnerable, immune compromised, pregnant women, young children, people like that, we've got to have better access to treatments. Like you may have seen, the FDA recently approved 2 different pills that may be pretty effective early in the course of therapy to keep someone out of the hospital. But demand is wildly outstripping supply of those right now. And so we're far from where we need to be for access to treatments, access to testing, good healthcare, stability, beds in ICUs, things like that. And so parts of the end game just mean we need more time to develop treatments, to learn more about optimal therapies, all of that. And the other challenge is, we know that infection is not lifelong immunity. Vaccine actually generates a more durable and longer lasting response than natural infection. And I think this point is lost on a lot of folks as we think, oh, natural immunity, surely that's better. It isn't. The virus actually perturbs our own immune response. The cells that respond to viruses are affected by the infection, and vaccine generates a broader, more durable response in general. And so the other way to get to the end game is getting more people vaccinated so that when variants come through, it's milder in the course of infection. So I think for the first time in the whole pandemic, we're starting to see what this might look like if the virus continues to evolve in a way where it's living with us and not killing as many of us. But there are a couple of steps that still need to take place before we're really there.
Thank you, Isaac. This one's for Sabel and Jim, and it has to do with students. What are the options for ongoing mental health services and other care during the month ahead for students? We realize that not just faculty are under stress, our students are under an extreme amount of stress.
Thanks so much, Mark. You know, that's a key consideration that we're really trying to monitor and support as maximally as we can. GL Black, Vice Provost GL Black, oversees a really phenomenal team focused on student care through the Student Care Network that really ranges from well-being in terms of exercise and self-care all the way through more high level and acute support when students are really struggling. So I would defer to GL's expertise, and he's not on the call to give very specific details of the range of supports that students can access. But just to say that if faculty are concerned about students, that we have a really great one-stop shop of ways to signal concern for students through that system of support. And similarly, if students yourselves are having those concerns, you too can reach out through that one-stop portal to let folks know that you are experiencing difficulty and want immediate response. My understanding is that the response time is very, very quick. The solutions are multiple and they're really designed to meet students where you're at. Jim, do you want to elaborate if I've gotten anything wrong there, or if you have additional insight?
Oh, you've done a great job. There's a robust university counseling center that's on the other side of the spectrum of well-being. So we have such great resources, and I love the one-stop shopping access.
Thank you, Jim. Thank you, Sabel. This one's for Tracy. Maybe it's a little bit of a repeat, but if a large number of students in a particular class are isolating or quarantining, can we run that class in a hybrid mode? And will any classrooms be set up for that?
Yeah, that's a really good question. And it's certainly part of the purpose of the what we're calling Sentinel, which is really just random monitoring. Testing is to try to help us identify if we find that ourselves in that situation. What I would say is that nothing's completely off the table, right? We want to be, as we've always been, responsive to the environment in which we're living and working. And if we find that there's a situation like that where classes effectively has such a high percentage of absences that we can't meaningfully teach it without some adjustments, then we're going to figure out, right, some way to ensure that we teach the students and make it possible for academic progress to continue. And what I'd simply say is when those situations arise, right, we will engage quickly and fully and in due deliberation with the relevant people at the school level, whether, you know, the individual faculty member, if it's an undergraduate course, the associate dean for undergraduate studies, if it's a graduate or professional course, a corollary associate dean. So we will be there. What you shouldn't do, though, is make decisions on your own. It's really important as a university, in the interest of equity across all students and faculty, that we make decisions that take into account the environment and the other decisions that we've made in similar circumstances.
Thank you, Tracy. So we're nearing the end of our time together today, and I'd like to thank everybody for their questions. We've certainly hit on many different topics. We're keeping a record of all the questions, and so if they did not get asked today, they'll be posted and addressed on the health and safety website. And a recording of this town hall will also be available there for later viewing. I'd like to thank again all of our panelists for being here, and thank you for attending. This concludes the town hall, and I hope you have a great rest of your afternoon.